maybe a few questions. Professor Chan, just very briefly. Barry, thank you for coming back. It is just very simple 3 cases. Taiji, please. Very simple 3 cases, and I will ask maybe everyone one question to make it fast. So this is a 30-year-old gentleman who has type 1 diabetes. He comes with a decreased vision in the right eye for the last week. He was never treated, never examined, just comes like that. Visual acuity is counting fingers in his right eye, and the left eye is normal. And wide field imaging shows this picture that is basically what we can see is just this pre-retinal hemorrhage over there, and difficult to see something else. However, fluorescein angiography shows the hyperfluorescence from this pre-retinal hemorrhage and a plethora of neovascularizations in both eyes. And my question, and maybe I'll start with Barry, just to show the OCT, just because it's a nice picture showing the pre-retinal hemorrhage. And my question to Barry, and I'll please have all your answers very fast so that we can continue. From these treatment options that I put up, maybe there is something else, observation, PRP, surgery, or anti-VEGF, what would be your approach and why?
It's an interesting question, and if you go back one slide, there's an extra detail that there is that you can see the hyaloid, OCT,
yeah.
You can see the hyaloid overlying the pre-retinal hemorrhage, so it's clearly quite sequestered, it's unlikely to break through. A challenge because Protocol S would have us do anti-VEGF injections, but our history would have us do PRP. It depends on the patient reliability. I probably would start with anti-VEGF. I like to start with that, but I'm always nervous about patient follow-ups. I'd have to get a sense of, is this a brand new patient you mentioned? Brand new patient shows up with that much disease, a 30-year-old, that tells me they're probably not been very well managed, so I'm suspicious to begin with. So he's probably, I forget to say he, probably going to get PRP, but I'm going to try to give a couple of intravitreal injections and see if they come back on time and what their lifestyle is and all those other things. There would be a balance between PRP and anti-VEGF.
You mentioned Protocol S that was nicely shown by Professor Chan. However, these patients actually with this subretinal hemorrhage, pre-retinal hemorrhage were not included, if I'm not mistaken, in the study. Yes, please.
I'd like to try the laser first, the thermal laser, because this bleeding is very fresh. And you can see the posterior capsule of the vitreous is thick. So why don't we just try laser to punch a hole on the posterior? Yeah. So let the bleeding is flow out. And I think it will be very okay. I have several experiments.
To say what you're doing?
I want to, sorry.
Let's have Professor Taiji just talk and then yourself.
Yes. I prefer surgery for the first eye, at least.
Please.
Typical case for surgery.
Surgery. Okay, so I'm very happy because that's what we did. And visual acuity improved to 40. It didn't come back for further imaging, but we decided that in this situation, specifically because of what you said, Barry, that the posterior hyaloid was still attached because of the non-compliance, and we are not comfortable with the punch iridotomy. I don't have a lot of experience with that. Barry, last comment?
I agree that the punch, it can be done, but there's a risk. That's a moderate amount of blood, but there are some evidence of some damage to the macula. So you can do it, but it's risky. We don't generally recommend it.
And
it can be very damaging. It can be okay, but it can be dangerous. Yeah.
Okay, next case. This is a patient that is 72 years old, very simple case, come with decreased vision for the past 2 months. We thought it is diabetic macular edema, and the question is how he had 3 injections of bevacizumab and still looks like that, so he still has significant edema. So very briefly, maybe Sung Young, do you want to say what would be your approach in this situation?
So in this case, I would like to switch to Ozurdex or the Lucentis or aflibercept.
Which of the 3?
First choice for me, Ozurdex, because the patient age is up.
Because he didn't respond at all. Barry?
I'm not a big fan of bevacizumab in this situation, so I would probably first switch to aflibercept up to 3 injections. If there's no response, then I'd quickly go to Ozurdex.
And aflibercept also because the visual acuity is reduced?
You didn't say how much, it said reduced, but 20, 50 or worse.
Or worse, you would go according to protocol T.
Yes.
Taiji?
Yes.
Surgery?
I like aflibercept because my friend of Bayer in this seriously, we don't have Ozurdex. I don't have any CY.
Okay, Professor Chan, would you do otherwise? Then, if you could.
Do we have any history of any corticosteroid response? Do we know the patient has?
No, we don't. No.
Yeah. So usually I would try another anti-VEGF, but in the United States we also have to consider the patient's insurance. Unfortunately, depending on what insurance. But if this insurance is not an issue, well, we have samples. We would use probably aflibercept.
Yeah. Okay, good. So this patient was treated by Ozurdex and actually did very nice, only for 3 months. Unfortunately, lasted only 3 months. Last case. This is a little bit more complicated case. Patient that comes with many diseases, 85 years old, please notice. He is known to have non-neovascular AMD in the right eye and geographic atrophy in the left. He just had phaco surgery. And 2 months after surgery, he starts to complain about gradual decrease in vision in the right eye. Visual acuity is indeed reduced to 645. And anterior segments are normal, nice pseudophakia. I'm sorry. And this is what we see. The point is the right eye, okay? So you see in the last fluorescein, you can see petaloid accumulation, and pretty much hot disc, or even more than hot disc, I would say, and it's very significant edema. The left eye has the geographic atrophy that we know, and we're only talking about the right eye. So first of all, I want to ask you, what do you think is the diagnosis? And do you want maybe to refer, any of the speakers that want to say what he thinks about the diagnosis? Because it could be pseudophakic CME, it could be ion or nion with macular edema, vein occlusion, maybe as what was the concern to the treating physician in my department was the significant leakage or hotness or swelling of the disc. So also some brain tumor or neuroretinitis were questioned. So just in one word, Barry, what would you think is the diagnosis?
I'm not sure.
You're not sure. Taiji?
That is 3 words.
Guess one of the, anything that you would guess.
I would say it's still probably pseudophakic is the most likely.
Taiji?
I have no idea.
No idea. So you?
I think the one most possibility is pseudophakic.
Pseudophakic. Please? And?
Combined with what? Pseudophakic plus what?
Okay, so we did a visual field. The patient was not able to do a Humphrey, so we just didn't show anything that can be suggestions for ion. The people thought about ion mainly because the disc, according to them, was too swollen for pseudophakic CME. So at this point, what would be your treatment option? What would you do?
So I see some disc leakage, so I would like to go first the steroid.
Steroids. What? Topical?
Intravitreal.
Intravitreal. Taiji?
Yeah, I do the same thing.
Barry?
Same thing.
Speakers. Okay, so actually this is how the patient was at presentation, and we thought that it may be pseudophakic CME. We just gave him prednisolone and Evonac eye drops, and he did very well. So you were right in your assumption, and that was the treatment. Thank you very much for
Thank all audience and speakers. Thank you.